Hello, good morning, everyone. My name is Martin Call. Along with Daniela Rodriguez, we make up group number 5. And today we'll be presenting on Chapter 7 of Evaluation, Comparison, Group Designs. The primary goal of this chapter is to understand biases and key evaluation methods for impact assessment. So let's start with a simple idea. Whenever we create a program, maybe a job training workshop, a mental health campaign, or a nutrition project, and we want to know if it made any real difference. Did people actually improve because of the program, or would they have improved without it? And to answer this, evaluators use different what is called an impact evaluation, which is basically just a study that measures the real effects of the program on people's lives. So the strongest way we can measure this is with a control experiment. When people are randomly divided into two groups, people that did take the program and people that did not. And it's like just like a science experiment. It's clean, it's randomized, it makes sure that everything is fair. But in real life, especially when it comes to like social programs, you can't randomly assign people. For example, you can't randomly stop half the poor families from getting food assistance or randomly deny patients medical treatment. This will basically be unethical and unpractical. So what do evaluators do? They use comparison group designs. And how it works is that we find a group of people who didn't take the program but are as similar as possible to the people that did, and then we compare the results. So comparison group designs, they estimate counterfactual outcomes when randomized controlled trials are not feasible. So this basically, the main purpose of this is to estimate what would have happened without the intervention. And there are a lot of like practical advantages of this. It is less intrusive, especially when implementing in healthcare settings. It's not only like more feasible, but it is cost effective, and it can utilize existing data with natural program variations. But with this, it also has a lot of key vulnerabilities. So we have different types of biases, such as selection bias, secular trends, maturation, inferring events, and even regression to the mean, which we will discuss continuing on. Understanding bias in healthcare evaluation. Bias is a word that we hear a lot in research, but here it has a specific meaning. In program evaluation, bias means that the results we see are not a true reflection of reality. Something has caused the results to lean to one direction. Think of bias as a kind of a blur of a picture. When you take a photo through a dirty window, the image isn't clear. The same happens when with research. Bias clouds the truth. In impact evaluation, we usually compare what did happen to what would have happened without the program. The second part, what would have happened, is what we call the counterfactual. The problem is that we can't actually see the counterfactual. So we can't rewind time and watch what and see what would have happened if the program didn't exist. So we estimate using a comparison group. People who didn't get the program, if the comparison group is similar to the program group, our estimate is good. But if there's differences between them or outside events that affect only one group, our estimate becomes biased. That's why bias is one of the biggest challenges in evaluation. The author, Rossi, explained that even small sources of bias can make us think our program worked when it really didn't, or it failed when it actually helped. So let's go through the main types of bias with step by step and with examples. Selection bias in healthcare. The first and most common type is selection bias. Selection bias happens when people in the program and those in the comparison group are already different before the program starts. And the differences affect the results. For instance, imagine a vocational training program for unemployed workers. If the people who decide to join are either more motivated or more hopeful, they might work harder and find jobs faster. If you compare it to people who didn't join, who might be less motivated, it could look like the program caused like a huge improvement when in reality, motivation was the key factor all along. That's selection bias. It's not the program, it's the people. Now, there's also a subtle form of selection bias called altruism. So, altruism happens when people drop out of the study or that the data is lost. Maybe they move away or they refuse to answer follow up surveys. If the ones who disappear from the program are different from those who stay, for example, maybe only the most successful people answer at the end, the results become biased. The same can be said for the comparison group. If only certain types of people respond, we are no longer comparing apples to apples. So researchers must try to keep track of everyone who has started in the study, even those who dropped out of the program. It just helps everything be fair and the results more true to the reality. So secular trends as bias. So the next type of bias is secular trends, and it's basically just a fancy way of saying natural changes that happen over time in society. For example, let's say a program aimed to reduce birth rates within a city, but at the same time, birth rates were already falling across the whole country, maybe because of like economic shifts or cultural changes. If we don't take that into account, our program may look like it have worked wonders, but in reality, the drop in births may have happened anyway, even without the program. The same thing could be happening in opposite direction. Maybe there's a drought, a recession, or a pandemic that affects people everywhere, making the program look less effective when it really is. That's why evaluators must try to choose comparison groups that live in similar areas or face similar conditions so that secular trends affect both groups equally. So interfering events bias. So another type of bias comes from interfering events, which is basically unexpected things happen during the program that change the outcome. For example, imagine you're running a nutrition program that gives food supplements to families, and halfway through, a major storm destroys the crops and causes food shortages. If the storm only affects the communities like receiving the program, their health results might get worse. And it's not because like the program failed or anything, it's because the disaster interfered. Or something on the complete opposite might happen. Suppose a health campaign is running in one area and at the same time a hospital opens there. People's health improve, but is it because of the program or because of the new hospital? That's an interfering event. Evaluators have to be basically aware of what is happening around your program and note that anything may have caused like an influence that may affect the results. So maturation bias. The next bias is maturation, which refers to natural changes that simply happen because time passes. And this is because people grow, they heal, and they learn over time without any program. For example, a reading program for second graders might show a big improvement in reading skills after 6 months. But kids' brains are rapidly developing at that age, and the program may not have affected that because they would have improved either way. Unless we have like a good comparison group, we might mistakenly think the program caused like a huge improvement. So maturation bias can also happen with adults. Imagine a program that teaches older people about exercise and health, and then after a year, we find out many of them report health problems. But that might not because the program failed. It could be because they are naturally aging. So evaluators need to recognize that changes may normally happen over time, so we don't mistake those for problems within the program. So regression to the mean bias. The last type of bias we'll discuss is regression to the mean. And I know it sounds very technical, but it's actually very simple. It means that in extreme situations, naturally move backwards to normal levels over time. For example, imagine a city has a unusually high number of traffic accidents in 1 month. The government installs speeding cameras right after. The next month, accident numbers go down. It looks like the cameras work, but maybe the spike was just randomly high at the point that it would have naturally dropped. This regression to the mean, it states that things that are naturally high and low tend to settle closer to the average later on. This can trick evaluators into thinking that their program caused a change when it was naturally going to be corrected either way. So the key is to collect data over many points of time, not just before and after, to see if the trend really changed that was caused by the program. So now that we have like discussed the different types of bias, such as selection bias, secular trends, interfering events, maturation, and regression to the means, let's take a step back and see why this matters so much. So, bias is what threatens internal validity of an evaluation. That is, whether the study truly measures what it claims to measure. So, bias cannot fully be if bias is not fully controlled, our results can be misled, which may cause us to waste money on programs that don't actually work or cancel programs that do work. This is why professional evaluators spend a lot of time designing studies that minimize bias, choosing fair comparison groups, um, collecting detailed background data, and then using statistical methods to adjust for differences. In short, no matter how clever a program looks or how big the changes appear, we can't really trust the results until we have fully ruled out the bias.
So, hello everyone. Moving forward, I will talk about the comparison group designs. So, in evaluation, sometimes randomized controlled trials simple are not possible. In those cases, comparison group designs help us estimate what will happen without intervention. So, there are four main designs we can use: naive estimates, covariate adjust regression, match comparison groups, and interruptive time series. So each one has its own strengths and weakness. For example, naive estimates are simple but prone to bias, while regression and matching methods statistically control for confounders. So the choice of design really depends on what data we have and the purpose of the evaluation. The naive estimate design is the most straightforward. It simply compares the average outcomes between people who participated in the program and those who didn't. So no statistical adjustments are made, so it assumes both groups are naturally comparable, which in reality is rarely true. Because of that, this design is highly vulnerable to selection bias and can easily overestimate the program's effect. So it's best to use only for quick or exploratory evaluations where we just want an initial idea, not a definitive conclusion. So let's take a diabetes management app as an example for naive estimates. Suppose researchers compared HbA1c levels between app users and non-users. So if users show better results, we might assume the app work, but users are probably more motivated or health conscious from the start. Since this design doesn't account for those baseline differences, the effect could be overestimated. In other words, what looks like a program impact might just reflect who chose to use the app in the first place. So to improve accuracy, we can use a covariate adjust regression design. This method compares outcomes while controlling for pre-existing differences such as age, gender, or baseline health status. So by adding those variables as covariates, the model statistically levels the playing field. So the key idea is to isolate the program's real effect from other influencing factors. So for an example of covariate adjust regression, imagine evaluating a smoking cessation program. A naive comparison might show higher quitting rates among participants, but maybe those participants were already more motivated. So a regression model fixes this by including variables like age, gender, years of smoking, nicotine dependence, and prior quit attempts. So after controlling for those covariates, the estimated effect becomes less biased and more representative of the true program impact. So now I will talk about the match comparison group design. Takes another approach. Instead of controlling it statistically, it creates a comparison group that closely resembles the program group before the intervention. So each participant is matched with someone similar on key characteristics like age, income, education, or region. And one popular method is the propensity score matching, most known as PSM, which calculates the probability of joining the program and pairs participants accordingly. So this reduces selection bias and makes both groups comparable. A great real-world example is the India's contingent cash benefit program in 2005, designed to encourage hospital deliveries. Researchers match women based on factors like state of residence, poverty level, education, prior childbirth, and age. So after matching, results show a 43.5% increase in hospital deliveries and a reduction of 2.3 neonatal deaths per 1,000 live births. So by matching, they ensured the two groups were comparable, so the observed improvement could be confidently attributed to the program itself. So the last group design is the interrupted time series design that analyzes data collected at multiple time points before and after an intervention. So the interruption is when the program starts and we look for changes in the trend or level of the outcome afterward. For example, a government introduces a new vaccination policy in 2020 by comparing infection rates across several years before and after. We can see if there is a noticeable shift. So this design works especially well for policy level evaluations where randomization is not possible. So here we have a comparative analysis of four key evaluation designs used in healthcare impact assessment. So let's compare them quickly. The naive estimates, simple but biased. The group design covariate regression. It's more statistically and controls for confounders. The match groups, it balances groups using observed characteristics. And the last group design is that is interrupted time series is great for analyzing population level trends. It's the best design depends on what we want to learn, the quality of our data and resources available. So in healthcare research, there's always a trade-off between practicality and internal validity. So selecting the appropriate evaluation design requires considering program characteristics, data availability, and evaluation objectives. So what is the primary goal of your evaluation? So choosing the right design starts with the goal of the evaluation. If we only need a rough estimate and can't randomize, use naive estimates. If we can control for confounders, use regression or matching groups. If we are studying long-term policy effects, use interrupted time series. So we also uh, need to consider how much data we have, how randomizable the program is, and what kind of impact we are trying to measure. So what are the strategies to identify and reduce bias in healthcare program evaluations? So no matter what the design is, bias control is essential. So for selection bias, randomize participants or collect good baseline data is important. For secular trends, to include time trends in analysis, for the interfering events, it's important to identify and control for external events like pandemics or policy changes. And for the maturation and regression, um, you can use baseline measurements and proper randomization. So the goal is to spot potential biases early, document them, and use multiple methods to correct them. So for an effective comparison group evaluation is required methodological rigor and thoughtful implementation. These practices enhance the validity and reliability of healthcare program assessments. So it is important to first identify all possible biases early, then pick the design um, that best fits the data and context, control for confounders through regression or matching, make sure the sample size is adequate, and collect data for a long enough period of capture trends. And finally, validate results with sensitivity analysis to ensure robustness. These steps makes our findings credible and useful for evidence-based healthcare decisions. So to conclude our presentation on Chapter 7, choosing the right evaluation design is crucial for accurately assessing healthcare programs. Comparison group designs are flexible and practical, but they require careful attention to bias and data quality. And when we apply these methods properly, our evaluations become more trustworthy and policy relevant. In the end, credible evaluations leads to better resource allocation and ultimately better patient outcomes. So thank you everyone for your attention.